I've loved coming here for the national parks. And then, as you know, Dr. Bob Carter, who was my chair, recruited me to residency, has come out here. So it's cool to see, the connections. Our field is very small. Continue to see that too, about running into people at different stages at different times. So for advancing. Right, so these are my disclosures. One of them is Neurosurgical, we will talk about today. And I think a key thing to understanding someone's story or the work they did, when you look at someone's CV, you really see the what, and not as much of the why or the how comes across with that. And I think that as we approach, our careers and really so much of our lives spent doing what we do, that understanding one's personal and academic philosophy behind the why of what they do is key. And one of my favorite quotes and really a mantra of mine is, you cannot manage what you don't measure. And some of this has been part of my personal life. A key part of who I am is a pseudo athlete. I ran the Boston Marathon a couple years ago with the Brain Aneurysm Foundation. I'm constantly pulling nurses, attendings and co-residents out to the Harvard stadiums to run. And I'm like obsessed with data trackers. This is your future CNS president, Brian Mayhead, showing off his Whoop band. You zoom in, he's stuffing his bicep with some paper towels from the OR as well. But just like the management and measurement of our sleep or recovery and integrating that into life and physical activity. The talk today is really in 3 sections: systems thinking and care delivery, technology-enabled surgical care, and then surgical education and objective metrics in training and particularly in residency. So my understanding of systems thinking really has been a journey, and a lot of that has come from the global neurosurgery component. And to get into that, it's actually taking another step back briefly. I grew up on a farm in rural Ohio, running around cornfields. Neither of my parents went to college, and it was a pretty humble life. And many of the people never really leave that town. So then a lot of my life changed when this happened. So here I'm on the right of this image. I was 13 years old. And my mother at the time was in her 40s and was diagnosed with an aggressive form of breast cancer. She was diagnosed with HER2 positive breast cancer. And at that time, there weren't many treatment options. So the prognosis was very poor. Thankfully, she was enrolled in a clinical trial for Herceptin, which most of us have heard of now. It really transformed care for these women. And I got to see her go from being a patient to a survivor, thanks to science. And her physicians were amazing and just really getting us through that. And also at that time, I think it was an amazing growth time for me. My older sisters were actually not really around. I had to look after my little brother and become the emotional glue that held our family together. And that created a lot more of the stoicism and resilience, I think, moving forward. So I went to Duke. Again, no one from my high school had ever been there. I applied early decision, had never seen the place. It just looked like a castle, and they had a good pre-med program. And while I was there, I got involved in this global health group called Global Brigades. I had never been barely outside of Ohio, other than North Carolina, once to California, and I had never been outside the US. So there was a trip going to Honduras for a medical mission. And about 2 weeks before we left, I was the vice president at the time, and the president couldn't go. So I was in charge of not only going for the first time abroad, but leading this group and pretending that everything was under control. And it's one of those fake it till you make it or fake it till you become it moments. I think for me, you arrive, you have military officers with M16s escorting you everywhere. It's one of the highest homicide rate countries. And citizens in the community lining up 300 people outside of a school to receive medical care. And I think the most striking thing for me then was actually a breast cancer patient, someone who had not had access to care, and her cancer was actually growing through her skin, so a fungating breast mass. And to me, the only true difference between her and my mother, who is now 25 years a survivor, was just the luck and circumstance of where you were born. And it was, confusing and infuriating, and that inspired me to continue exploring this world and trying to better understand the work that was being done. I went back the following year to Panama. I went to Ghana. I grew in leadership within the organization. But in Ghana, we were doing a public health mission, putting in latrines, water storage systems, and it really started to hit me of just contemplating how much of what we're doing is sustainable. The mission work there in that group, they had multiple universities returning to these cities to try to build capacity, but were we training the right people? Were we actually making ourselves irrelevant in the future? And thinking about this more of a systems level instead of a one-off thing. So, driving sustainable change, or was this just something more of a white savior complex of this makes me feel good, and or is it actually having a positive impact on the community? This is where global neurosurgery, I think, starts to have so many different applications to even what we do here in the States. So a lot of the principles are about thinking in systems. Workforce shortages are, they really highlight the importance of scalable training systems. Resource constraints change your prioritization of efficiency, workflow, and value. And it really depends on systems design if you're going to have true lasting impact. I then went to medical school in 2014. I got involved with the program of global surgery and social change at Harvard, and they were working on the Lancet Commission of Global Surgery, which came out in 2015. And I started getting involved in that group. I was in Rwanda on some of my winter breaks and summers, looking at laparoscopy and how does minimally invasive surgery in the general surgery world. What is access to that? How are training systems? Are the resources there even robust enough to sustain these technologies? The Global Neurosurgery Initiative, led by mostly Key Park at the time, was something that I started getting involved in. We, 2018, published a series of papers on the global burden of neurosurgical disease. And I left Boston for a year to get a master's in global health in London. Continued working with this group, and one of the women who I had met in Boston, and she's a neurosurgeon in the Netherlands. After I'd finished my master's, I was visiting her in Utrecht, and she had said, this is great work. You should continue this and really get a PhD with me. So it was not something I was gunning for a lot of credentials. A lot of this has come from friendships and relationships, people I've met along the way. And I still am involved. Now I'm a PhD co-supervisor to one of the only two neurosurgeons in Curacao as they're trying to build their system there. So this was 2025. Leiden is the oldest university in the Netherlands. And it's a series of the papers of work I've done from med school masters and then continued working on during residency. And I'll show a couple of things of where my niche was in that. And it's really about training and systems. When I was in London, there was the global neurotrauma launch at Cambridge in the UK. So I hopped on a train and I joined Key Park at that meeting. And there was this huge emotional debate about non-neurosurgeons doing neurosurgery. Sometimes it was general surgeons, sometimes it was general practitioners or clinical officers. And irrespective of my opinion at that time, I didn't feel like I knew enough about the topic. But it was, some people saying something is better than nothing, others saying something is doing harm. And getting back to that concept of you can't manage what you don't measure, it didn't really seem like there was much data on this topic. We know that from estimates that 23,000 more neurosurgeons are needed, so there is a workforce shortage. Task shifting is this concept of training another individual with a different or lesser training to do the tasks of typically for example, a neurosurgeon, but then they're out on their own. And task sharing is this concept that many of us, employ every day, where there's back and forth and iteration and shared collective input and responsibility over care. Many of us do this with nurse practitioners, physician assistants, and it's really like this collective input and umbrella of a team dynamic. It's about task sharing. Might have frozen. There we go. So I pulled together a team. We put out global. How do you define the problem? We found out that of 47 low middle income countries who responded, 20 countries were reporting. So this is ongoing. Whether it's right or wrong, or whether it's being done safely or not, it is happening. Mostly it was to general surgeons, but also some general practitioners and non-physicians. And within neurosurgery, mostly it was for emergency interventions such as burr holes, craniotomies and craniectomies, EVDs, occasionally a shunt. And mostly this was not supported within the Ministry of Health or formalized systems, and few opportunities for continued professional development for these individuals. So then the next question is, if this is happening, how should it look? Is there benefit to having a systematic approach to how task sharing or task shifting is done? And so in a different global survey about perspectives on task shifting and sharing, it seemed to really be consensus around task sharing is preferred to shifting. There should be oversight, standardized training, some type of competency-based evaluation, and integration into the health system where it's needed. This is not necessarily a permanent solution, but in many of these countries where there are many workforce constraints, something that is done in concert with building up the local system. We boiled that down to some of ideal model concepts. A lot of this is based on task shifting and sharing within anesthesia or other subspecialties as well. But focusing on the training phase, practice phase, and really a maintenance phase of providers and training. And then searching for a real life example through one of my co-authors on a paper. He had told me that this was being done in the southern part of the Philippines. There were 2 neurosurgeons for 6 million individuals, and one of them was training general surgery residents how to do emergency neurosurgical care. So I went and visited for 2 weeks, and I moved there for 4 months during my master's. And didn't really have any connections there to Harvard or King's, so it was a bit of a leap of faith that this would be my master's project. But worked to understand what they were doing, interviews, going through tens of thousands of paper records to see if the patients who were operated on in these emergency settings, if the outcomes from what we could gauge from the retrospective review were similar or on par with when the neurosurgeons were doing them, either there or at the nearby private hospital. And really understanding, how are they actually functioning in this, and how does that match with the theoretical ideal system? They staffed similar to how you probably staffed your cases this morning. So a text Viber thread, a picture or video of a CT scan, the overall assessment and plan. And once they were signed off on an emergency cranie, they would be able to do them, but there was still, when the neurosurgeon was back at that hospital, would round on those patients with them. And there was still that shared continuity of care patient. And ultimately, liability is something that always comes up in these circumstances too. And ultimately, the liability was primarily, in this case, still in the neurosurgeon. There are different things with the general surgeons at different hospitals as well. Some of this has gone into the comprehensive policy recommendations for head and spine care. It's one line in the matrix, but there's some of the background work about the differences between these two models of task sharing over task shifting and how one would institute it. It's been in some of the national surgical plans at country level, with the ministries of health, but also ministries of finance. If you're making a national surgical plan, you can't do this without resources and thinking about how you fund them. And then some of us will even remember the COVID pandemic, and we were task shifted. I was an intern, and on neurosurgery, and I became a medicine internist in a COVID unit. So, in doing this, these same principles, when you again take a step back and look at the system, those same principles apply. So again, while it's been global neurosurgery to really push me into thinking more of systems of care, typically in low and middle income countries, those apply to low resource settings, but they also apply to high resource environments as well. In 2023, I was the CNS Quality and Guidelines Scholar, and we put together the symposium for a couple years of really quality, but quality is such a systems level issue as well. So thinking about enhanced recovery after surgery, we were talking last night, what is the system of spine care? So it's obviously neurosurgery, orthopedic surgery, but pain doctors, anesthesia doctors, PM&R, rehab, and taking that step back and understanding the whole system or the flow chart of care really allows you to measure all the different time points in the patient's journey and have effective implementation of change. So this has been something that I've really enjoyed thinking. I have, there are some of us in the field who love thinking about subcellular level, RNA-seq and single cell sequencing, and really zooming into the project. And some of us like the zoom out 30,000 foot view. I think both of those are so essential and everything in between. But for me, the systems level of care has really been where I found a lot of joy and a lot of ability to affect meaningful change and value in care. So this just again revisits that, we see this in workforce shortages, we see this in resource constraints, and the systems design leads you to a lot of ways to affect the pathways of care for patients. The next part of the talk is really about, talking about managing what we are measuring. And the goal in a lot of what we do is to improve precision, reproducibility, efficiency, and in a way, minimally invasive care. And minimally invasive doesn't mean that everything is endoscopic, but what's the least disruptive that you can be? It's really a mindset to still execute on the goal of the surgery, the goal of the intervention, but in a way that allows the patient to recover in the most rapid and efficient way and have the greatest long-term solution. And I think we're in a very cool moment right now. There's, if you're not using AI on a regular basis, whether you're ChatGPT, ways to better prepare for your case, or leveraging navigation in the OR technology, the rate of change in technology right now is extremely rapid. It's very exciting. We're having more and more growth and engagement between academia and industry, and there's just a lot of amazing potential to get involved in leading how technology will continue to change our field. My intro to the tech standpoint started with EVDs. So who here has placed an EVD before? Okay. Who here has ever misplaced an EVD? Yeah. And it's the most common neurosurgical procedure we do. You start doing it as an intern, sometimes even a sub-I. Sometimes the patient has a huge amount of shift. So you're going at Coper's point and you think, in theory, you're perpendicular, but you miss, and then you're doing your second or third pass and you get that post-op scan, and then there's a hemorrhage. So it's something that's frustrating. It feels Sometimes then you feel more powerless over the situation. Sometimes they're on Plavix, they have terrible liver disease. And, it's something that is still a challenge that we often just do blind. Same way they did it in the 1800s when, Coker defined that point. And so when you think about this, what are the pain points, why, and how can it be better? And zooming in on that project, I had started, this was one of my first projects as a med student. Mohammed Abdelbar now is my future fellowship director at Duke. He was a chief resident at Brigham at the time. And you start simple. So boiling a problem down to simple things. So yes, sometimes you, even if you're at Cooper's point, you get a hemorrhage. And even if they're not on anticoagulation or antiplatelets. One of the things is portable veins. If you're doing a burr hole in the OR, you have a perforator, typically you can see if there's a portable vein and avoid it. But if you're just using a hand drill in the emergency room, you can't really see. So just looking at how many times, if you go in Coker's point, how close are you to a portable vein? That if you moved slightly, could you find a trajectory that was safe for a patient-specific safety zone? Seemed like 20% were near a range of that catheter being in contact with the vein. Sometimes if you do slow past that vein, will move out of the way. But the key thing here is there were patient-specific safer zones that might just require some adjustments. So if that's the case, and how you translate that to the bedside and in the ED and the ICU, we started, playing with this idea with engineers from the Beast Institute, with radiologists at the Brigham. We did machine learning to vessel segment CTVs. I'd be presuming that a patient has a CTV, and then how do you translate that onto the patient? So our first go was, using the newest cutting edge 3D printer that prints super quickly. You do a surface map based on the CT, you print this, it gives you basically a Bijar guide that's mounted perfectly into that patient and place the catheter there. But a lot of this seemed like it's way more burdensome. It's not actually going to be feasible at the bedside. And, if you're going to be trying to push things forward and change and innovate, you're going to end up killing so many projects along the way. So you have to be comfortable with the fact that you can't fall in love with one particular idea too much, and you need to continue iterating. So some of that was in 2016, 2017, 2018. In 2019, Bill Gormley, who is next to me in that picture, he was the neurosurgeon and he runs critical care at the Brigham. We've been working on this project, but we met these two guys in yellow circles, and they're really, I called them kids at the time because they were fresh out of Harvard undergrad. They were very interested in computer vision. We met them through the Harvard Innovation Lab, and they were considering using computer vision either to fix engineering problems for airlines or do something with healthcare. And they had some healthcare interests. We met with them and started working together on this project. So, what this is, we now have founded Zeta Surgical, but it takes the computer vision is like a 3D camera. I used to liken it to LiDAR and your Tesla, but I guess Tesla does not use LiDAR anymore. They're more advanced. But it takes a 3D surface map of a patient's face and call it snap surface alignment, but it matches that to the patient in real time. Our first iteration, this was at 5 hertz or every 0.2 seconds. And when you use BrainLab or Stealth in the OR, you're selecting those manual points, and maybe you choose 50. This takes 2 million. So the accuracy and ability to track is a little more. It can account for movement because you have so many different points. So we did these cadaver studies. Another key thing is, what if you get the scan and then your patient gets intubated before you place your EVD? So if we cover up and not use the lower part of the face, what if your towel draping is covering up some of those key features? What if it's a dark room in the ICU versus a super bright, well-lit room in the emergency room? So testing all of these in the cadaver lab of all these different conditions, with our navigation system, and then placing serial catheters to simulate an EVD, scanning them and looking at our accuracy, even with movement and motion. And we were able to show that looking at you have three things: surface registration error, the target registration error, so how both of those move, and then as well as the user error. So how there's always going to be some human element of error, and you need to incorporate that. And the lighting conditions, were still under a millimeter. And then even when we incorporated the human error of this, the user error, it was only 1.6 millimeters. So this is on par. Actually, a lot of brain lab and stuff promises 2 millimeters. So this is without pain. This is a patient who's moving in the emergency room, or someone you take to the ICU bed. There's going to be some movement there, and this still allows that accuracy. Key things we found in other literature is people won't use a new product if it's going to take more than 10 minutes. So our first goal was 5. Now it takes 2 minutes to set up. You reel the card in, you turn on the camera, upload the scan, and then it's ready to go. And it will continue tracking this in real time. This was just an example of one of the early renditions of this snap surface technology. So we 3D printed a lot of phantoms to use in our studies. You would move, and then the green surface map, you can see it adjusts, and that's snap surface part. Now we're at a way faster, that's like 20 hertz. And this was an AR view of like your target entry point into a ventricle at the time. Surgeons, we don't really like too much change. So now our updated version basically looks the same as BrainLab and Medtronic. So you have, we actually did a partnership with BrainLab, but your views and everything on the interface are almost exactly the same as everyone's used to with inline 1 and 2, a probe gyre trajectory view, and then axial, coronal, and sagittal. So with Zeta, so I led as first author research, most of the primary research on these papers was I still advise for the company. Is not a founder. That takes a ton of time that you don't have as a med student or resident, but and still involved more on the advisory role for the team. We've trained it so you can track it with a robot in this last picture. So as you move the head, the robotic arm is constantly tracking it as well. Tried things with low frequency focused ultrasound. So if you want to open the blood-brain barrier for chemo delivery at that specific site of just above the tumor, that's an application. And then, now we've had 4 510(k) clearances with the FDA, and are continuing to work with different hospitals and use cases. I had been having dinner with Elad Levy at Buffalo, and this was a couple of years ago, and he's like, I want one. So they have one that they're continuing to use even for ENT procedures, or things where you don't necessarily need to pin the patient, but you still want some type of navigation. And then just last week, they installed a TMS navigation system. So this was down in Florida, and we just got FDA clearance for that as well. So, that was my first introduction really to a startup. A lot of learnings through that process, going from, what is your pain point? Is this pain point something that's also felt by many other people? And the bigger the pain point, the more likely it's going to resonate with others, and that if you create a solution, it's likely to be used. And I think there is an element of you need to make a financially feasible solution for it to actually be able to hit the market and then ultimately impact patients. So thinking about the financial and strategic parts of this as well is something that I did not, my mentor had an MBA. I did not really have as much understanding of, what all goes behind getting something from idea to patient and really through the market with that. So, during my, we did 2 research years at National Neuro, and one of those you're on call nights and weekends, but I was able to do a full-time 2-year MBA at Harvard and explore some of this a little bit more. During my summer, it's mandatory to do some type of internship. And I was lucky to secure one with J&J, and I was working on the Vela spine robot. At this time, I think the funny thing to my team is I still was pretty adamant that I was going to be a brain tumor surgeon. I, loved, in my junior residency and as a medical student, the philosophy behind, especially awake craniotomies, of being able to balance quality and quantity of life in real time with the patient. And sometimes it means leaving tumor behind, so increasing quantity of life, but preserving who that patient is and their identity and being able to speak. As I continued on in training, I loved the athleticism in the OR of spine. It is like a workout sometimes. And my appreciation for mobility for my personal life, helping patients get back to that, being able to move without pain, being able to just move again freely. It's so much of who we are and what brings us joy. And I started falling more and more in love with spine. And then my love for med tech, during this internship too, working with robotics, working with all the new tech that is in spine, allowed me to gain my appreciation on top of just really enjoying a lot more of the cases during residency for me have that existential crisis and make that switch into spine. I think a cool thing in working for, instead of a startup, but for a large company, is innovation is very different at that stage. I was able to apply some of the learnings of business, think about how innovation happens in very well-resourced teams. Innovation is typically slower the bigger the company, but it's important to understand how those things get generated. How do you have design surgeons in-house or consultants or key opinion leaders? How do you get through the FDA and run big trials? And how does this ultimately then get into the hospital and into the surgeon's hands? One of the things I did while I was there, to design a lot of the training programs for the surgeons and the sales force on this. So I had a lot of time with the robot and working with, in the cadaver lab and also on models. And there's just like a really amazing way to better understand the technology and what's possible with enabling tech. And not everything, definitely not everything needs to be robotic. And we would joke that at times a robot is a glorified drill guide. And it's not that much addition and accuracy compared to like stealth navigation. But there are continued things that are coming down the pipeline. I saw a demo of a robot a couple weeks ago. That's, you pre-program the bony drilling that you want done, and it will do it with a 2 millimeter margin, and they're working on moving towards 0. So I think it is enabling tech. It also allows you to execute the exact plan that you intended. What that allows you to do is capture a lot more of that data. So if you freehand the screw, it might not be the exact amount of correction that you wanted, or you can measure it on the post-op imaging, but there might be more variability than if you can do something more reproducibly. And as we have reproducible plans and results, we can better understand which patients are going to do well, or what surgery is needed up front. And teaching is something that I really enjoy, whether it's in the OR or thinking about this and thinking about systems and how do you get done technology through regulation. What's the difference between a 510K, a pre-market approval or PMA, a breakthrough device, de novo pathway? So I've gone back to Harvard, and these are a couple of cases that are taught in a class called Entrepreneurship in Life Sciences. And this was mostly on the Impella cardiac device, but it's used as a platform to teach not only business students, but cross-registrants from the School of Public Health, MIT, PhD students about med device innovation and regulation. And if any of you are interested in some of this, I've gotten involved also like on the national level. The Washington Committee has a drug and device committee that I serve on, and we held a fun webinar the other week and hosted Adel Malik, who is for our vascular surgeons or pediatric surgeons of the E-shunt. So he was a co-founder of the eShunt. He's at Tufts. Emmett Iyer, who did a lot of innovation during his residency at Northwestern, including the Hubley drill. Fred Liss, who's an orthopedic surgeon, but created a hospital and now does venture capital. And then Lee Dry, who is actually from the FDA and was part of the TAP program, which is a program if you have breakthrough device ideas and you're about to be submitting to the FDA, they can help you get it more ready for that process. And then, how am I going to apply this in my day-to-day work in spine? I've not yet started at Duke, but I think part of it is having known Dr. Abdubar for many years and also as a friend. I've already started to get integrated into some projects with them. And some of the work is using some of this is manual segmentation. So how do we better leverage our navigation and technology and move towards auto segmentation to make these patient-specific corridors or entry zones, or really just similar to the EVD, is something empiric best, or are there patient-specific zones that are safer that we're just not tapping into? And how do we continue to evolve this so it is more automated and it's faster? And it's not like you're doing a half an hour pre-op plan for what can be a half an hour surgery. So, some of that is the segmentation of the SAP. We're looking at, creating a taxonomy or better understanding why robots fail, like why are people abandoning robot cases. This disruptive tech paper, this just came out this month in Journal of Neurosurgery Spine. This was an illustration of Dr. Shin, who was at MGH and now is at Penn, using augmetics to do some of the sacral removal of a chordoma. And this article, we just review a lot of the current technology, the evolution of it in spine surgery, and some of the implications for disruptive tech. Overall, I think you don't have to be an engineer to work on this. I think the best thing is when you create a really robust team, and you're all going to be so close to the patient that you feel those pain points more than anyone. And if you pay attention to that and you create good teams, you can think of these creative ways to problem solve and new ways to reduce invasiveness, improve patient outcomes, improve workflows, and really improve that reproducibility in data. The last part is, how does this kind of integrate with what we do every day, which is, all of us love being in the OR. And as a resident, you're here to train, and before you know it, you'll be graduating. Trust me, the days are long, the years are short, and you want to make sure that you are ready to have that final buck stop with you, and the patient outcome really be a result of not only your work, but then your ability to train and take a resident through the case. And if they, do something that you can salvage it and really be ready and confident in your care to help your patients. And I think the same principles of thinking about as a system, having objective metrics, and being intentional about the process is key, and even leveraging technology to do so. So traditionally, our surgical education has been very similar for many years, and we have Halstead model residency. We basically live here in an apprenticeship with graduated autonomy. There are didactics, you have skills courses and cadaver labs, but there's so many other variables at play. So, the cases that I'll see in Boston can differ greatly from the cases you'll see here, and even within a single city, cases that are coming to Intermountain Health or some of the community health centers or the VA are going to be different. There's also random case frequency. So, Jeff may get subdurals every night because he's a black cloud, and someone else might have quiet nights, or they're getting all the spine trauma. And so you're going to have a lot of variance in case exposure, clinical exposure, how much autonomy you're given based on which attending you're with. And just the other critical reality is that healthcare is changing. There's more hospital consolidation, there's more pressure on our attendings to get your OR time down, to be more efficient. There's medical legal implications about, how much time, is the attending present at the critical part of the case and documentation of that. So the level of autonomy can change and also vary based on where you are. Something I think that, we still have room for growth on in the field is how we actually measure our performance. In business, we talk about key performance indicators, so really specific subjective markers on how we track progress. Right now, the credibility of how good someone is, you can look at their case logs, but really what that tells you is if they scrubbed in or not. We take a multiple choice board exam. You call up the program director or chair at the other institution and say, can this person operate? And, hopefully there's like a, honorary contract there that they'll be honest, but there's always a hesitancy to not protect people who you've trained for a long time. So there are gaps in this, and then there are some assumptions based on institutional reputation. So spaced repetition learning is not something that's new. This is a concept that's been around since the 1800s. Who here has used Anki for study? Flashcards, so repetition, especially in high frequency, really helps mitigate the educational decay. So when you learn something for the first time, you get a rapid decay curve. And the higher frequency that you can repeat that exposure, it really flattens out that curve and translates into long-term retention quicker. We all use this when we study for exams, but how much are we using it for our technical skill? Again, so the bottom line with just the pink dots, that's your practice in the operating room. There's going to be variability. Maybe you do a whole week of ACDS and then you don't do them again for a few months. And your skill level and comfort with that, we all feel we get to do a lot of cases of duration, and you learn so much more and you feel your growth. And then sometimes you lose that when you have a gap. But if you can supplement that with something like simulation or something that's more controlled, then you can continue, again, mitigate that learning decay, the technical aspect of it, and really continue ascending on that curve towards mastery. Simulation also with technology is getting more feasible, more realistic and high fidelity. It's reproducible and is growing in affordability. So this was something I had done with my residency program. Have you guys heard of Upsurgeon, brain in a box? So Federico Nicolosi, if you next time you go to a conference, walk around the exhibit hall, you'll see these boxes set up at every microscope and people practicing on them. But there are a lot of different models. This is a pterional, there's endonasal, there's now spine models. And they're not perfect, but they're pretty good. And especially if you're learning basic steps in anatomy and repetition. So they also have virtual reality options, hybrid reality with AR, VR, and then these box models, which are very easy to work with. So what we did was a simple study, 6 weeks, split up the residents. Everyone initially went into the skull-based lab and did a pterional with instructions. And it was video recorded and then judged by outside neurosurgeons. And they got feedback on very definitive, and I'll put this up, but specific metrics and got feedback. Then one group came back and did this again for the next 4 weeks, while the other did not. And then there was a final assessment and just tracking progress, like Heard-T tests, you yourself or your own control. So this is everything from, that you hear occasionally in the OR, but getting very specific feedback on it. So how did you skive with your perforator, or is it jumpy? What's the angle of your B1 craniotome? How are your dural tappers? How clean is your dural opening? There's also anatomical identification. So different parts of the anatomy pointing it out. And, how quickly are you able to do this? Some of this will be model familiarity, but some of it will also just be the actual practice and learning with that specific feedback over time. Overall, we saw the controls are on top, the intervention is at the bottom. So in some of these, gross craniotomy scores, it was 25% improvement compared to 4 and 18% compared to 6 in the microsurgical, the gross motor skills. And then some of these tech or task-based checklists of like identification and that there was basically stayed flat in the control group versus 84% improvement in those who were practicing every week. This is just in bar chart form. It's not necessarily a surprise. The more you do something, the better you're going to be. But it is nice to, again, put objective metrics behind that and show that this is feasible to do in a residency program. After doing the cranial one, Stanford was interested in collaborating with us to repeat this for ACDF. So very similar study, similar outcomes. People get faster, they're more efficient, they're better with the techniques. And also qualitatively, people felt more comfortable going into the OR for a real case, given that they've gone through this in an iterative way. I think when we then think about MIS, so personally, I believe that a lot of again, MIS not just meaning everything needs to be endoscopic or everything needs to be tubular, but there's new technologies that are allowing us to enter different corridors and disrupt the normal anatomy less and less. But you're viewing things from stuff that is not your typical training. It's very different to be able to, do wide exposure of the spine, see everything, see the facets, know exactly where your screw is going to go, know exactly where the disc is, the nerve root is. But training for MIS requires a different type of cognitive skill training. It's different 3D anatomy understanding, spatial understanding, and in some ways it's shifting this operative mindset from seeing everything and knowing exactly where everything is and staying away from it versus knowing precisely where to act and how to act. And I think simulation is going to be something that is helpful for this. Space repetition learning, so making sure people have enough of the frequency to gain that confidence and that skill level. And it'll be something that we, all need to continue evolving and working on as these approaches become more prevalent. So, a lot of things that overall can seem disparate, but I think what really ties a lot of this together is zooming out and looking at things at a systems level and understanding how technology can better enable us to do what we tend to do and help the patients. I think when you think of systems, we're working on enhanced recovery after surgery pathways. We're going to be facing more and more movement to ASCs, home hospitals. And as we think about workforce solutions and multidisciplinary teams, systems is going to become more and more important as care evolves. For technology, navigation, robotics, MIS, endoscopy, how do we not only use technology in the best way, in a financially feasible way, but also partner with individuals and drive a lot of what the new technologies that enable us to do. And from the surgical standpoint is leveraging systems approaches to training and being mindful of what technology we are introducing and why and how. And again, all this you have to be mindful of what is the value of all of this. So, it's not just to do the coolest new gadgets and stuff, but resources are still something you have to keep in mind. But the value of a lot of things for patients, also providers, ergonomics, and longevity for our careers is critical as well. Some of this I mentioned, but I think we're moving as medicine and as a neurosurgical and a spine field towards more outpatient spine centers. Sometimes awake surgery, we'll see more and more AI-assisted workflows or even decision-making tools, and hybrids of navigation and endoscopic. This was a picture Abdulbar sent me from Duke of overlaying heads-up display with endoscopy. so you know exactly where you're acting. Some of this is just fun and cool to do and prove what we can do, but it's worth sometimes trying it, and then you can even scale back and see what's actually needed. So with that, personally, I'm hoping to build a very academically rigorous spine practice. I've had some MIS exposure, and a lot of next year I'll be really focusing on a lot of that at Duke with both the neuro and ortho teams, as well as general spine. And commitment to educational infrastructure. I think that's such a joy of academia, and being part of a program with a residency is investing in that education and training that next generation, and really collaborating and creating an environment that is rich for innovation. So helping people navigate that path, instill ideas, involving capital, venture capital for those things, really helping that transition from idea to patient. With that, I think the key things are, future won't depend just on our technical skill, but how effectively we redesign these symptoms and play a role in it. You cannot manage what you don't measure, and you keep asking yourself, what are those pain points, and why do we do what we do, and how can we make it better? So thank you, everybody, and I'm happy to take questions.
Yeah, David. Thanks so much, Katie. That was an amazing talk. You've done a lot in different aspects of systems and neurosurgery. And I'm curious about the last part about training education. Where the study that you had, where you have everybody do recursive learning and things like that. Where do you see that fitting? If, for example, like every programmer to do it, where would that fit in the day-to-day schedule, or is it a weekend thing? Just curious what your thoughts are.
Yeah, I think we all have education days. A lot of right now, I find a lot of our cadaver workshops and things are on nights and weekends. I think it's hard to ask people who are already here constantly during the week, and you're just probably going close to over 80 hours to dedicate more time. I think balance is really important to health and wellness, and just staying sane and fit, or any of that throughout training. So ideally, we did this during our education time week. There was a skull-based lab that we could use, and we had people come in. And sometimes it's set up for an extra couple hours, either earlier or later, if you want to go to an emergency case. But ideally, you're not just taxing people with more. I think being mindful and respectful of time is important. But you had a question?
Oh yeah, I don't know if I missed it. Sorry, I missed it in your talk, but I was wondering whether your 3D capture navigation system had you tried it on spine, converted to like.
Yeah, so we don't typically. So we're playing in a space that's more outside the OR. For spine, the key thing here is you need to have enough different 3D surface differentiation and non-deformable anatomical things to actually continue registering. Someone who's similar to us was 7D-Surgical, who's acquired by C-Spine, and they do a similar computer vision based registration. For spine, what you have to do though is expose the spine, and then it's doing that 3D surface map on spinous processes, facets, etc. But we're basically trying to play outside of the OR, and you can use it in surgery centers for like shunts, ENT, a lot of other things, TMS. But we didn't go after that fish. We also are trying not to be, fully confrontational with like Brain Lab. We've done collaboration with them. I would love hopefully in the future, but still disclosure. But it's a great idea. And you have to, that comes usually in the path of strategy of like, where do you want to play? Who are the other players in that? And how can you stay distinguished? But just looking at the spine, there's so much soft tissue movement. You need some type of fixed marker. And with 3D anatomy surface registration, there's nothing as stable enough to keep that.
Thanks for being here. It's awesome to see you, and your talk was
I was wondering, in each of the different buckets you talked about, it was very clear that you had to collaborate with government in some way, whether it was the WHO or USAID or the State Department of Global Health Work or the FDA, business world. I was wondering if you could talk a little bit about what it's like as an innovator and as a clinician in interfacing with government, and how you see that being able to make you more or less.
Perfect question from a White House fellow. And Jeff and I, we've met on the trail, we've known each other for years. No, I think the key thing you have to understand is also probably in the systems perspective is, you know, what context are you playing in? And you're not going to go about anything alone. You know, even as a surgeon, you know, we have our teams in the OR, and you need to respect that. And there's the floor walker, anesthesia scheduler. For the, I think the med tech perspective is an easy one to address first. So if you're doing device or pharma stuff, the FDA is going to play a major role in that. The branch of that, the CDRC, is going to be someone that you want to view as a friend. It's way better to have someone on your side than see them as your enemy, and engage them early. So if you're starting a project and you're thinking of submission, you can do pre-submission inquiries, you know, well beyond 6 months before you even plan to submit. And I think having someone to help shepherd you through that process, who's done it before, is so key and will save you so much time. But I think if you're going to have any type of regulation, whether it's, you know, government regulation from a global health perspective, or med device, early engagement, see them as your team, try not to create friction and just be respectful. Like, they're trying to do the best they can too. And those are simple human things, but sometimes we lose sight of that. In global health, some of that work, it was more just working even smaller scale with IRBs and hospitals and that. And it can be extremely challenging. And there are many delays and stuff. And again, finding the key thing whenever you do global work is like, you're not there to save them, and you do not know better than them. The first time you ever go, you should go to learn and make a friend. And that was a quote from John Tarpley at Vanderbilt, who did a lot of global surgery stuff. And like, you need to go with humility and find the people you need to talk to. They're often harder to find than you think, but there'll be someone on your team who can better point you to it.
Time for one last question, Sherman.
Thanks, Faith. So you talked a lot about kind of, you know, on one hand, global health and access, on the other hand, med tech. The problem is med tech has never been cost saving. It's always another capability added to the health system, hospital or more money.
Yeah.
How do you reconcile the two? Do you sort of, in your future, you sort of see them as two separate endeavors? Do you kind of think about them together at all? Yeah, no,
especially a lot of this technology is very high resource. There are ways to do it's like reverse innovation or re-engineering stuff to be more cost effective. There's a lot of that that's been done, you know, with less in my personal path. So Alex Golby at the Brigham has done Nuvos Nav, which is more of a mobile-based platform for navigation in lower resource settings. I think there's, you know, LifeBox with pulse oximetry and that. I think that a lot of what was most striking is being the privilege of seeing behind the curtain at J&J, and I have some NDAs, so I won't give you exact numbers, but understanding the cost of goods and the supply chain, and then the market price and the price that they give hospitals and give VAs and that. There's a lot more room for cost decline, I think, in the future. Like, the actual cost of these things, they're recouping a lot of R&D costs. There are ways to make these tools accessible for a lot more effective designs. Right now it's harder to do that, and things will be on patents and that. But there are opportunities. I think the actual cost of these things is not as high as they're charged. A robot does not cost $2 million. It's not even a 20th of that cost. Again, you're paying for the R&D, but there are ways to bring some of these technologies there. the key thing though about appreciating the system is you can't just bring equipment there. That happens in a lot of mission work. And you see it as coat hangers, or there's a whole area of junk of things that, because you don't have biomedical engineers, you don't have any of the equipment to get. So I think when you're bringing tech to those settings, it's like, what is the minimum need? You know, do you need a microscope? A lot of people just do stuff under loops. If you're going to bring that, or an endoscope, or in Rwanda, we brought, you know, there were laparoscopes, which are pretty applicable and pretty low maintenance and cost. But are you also, if you're twinning with them, which I think is a better model of recurrent visiting, you're training up people, you're building capacity, you can't just think about the surgeon. You have to think about the engineers, you know, the nursing staff that you're training, etc. So I do play in different camps in terms of like resources. But I think there's ways to bridge them. One of the ideas with that mask for the EVD thing was that's super cheap to create. And one of the engineers actually worked on, you know, could you apply that for either stereo EEG, you know, functional, like you print a mask, it gives you all the ports you need to place electrodes or that, or for DBS or those type of things. So how can you reverse engineer some of these for lower resource settings? I don't have many active projects in that now, but I think it is still important.
Well, Faith, thanks so much for that overview, and thank you for taking the time to come out. We really appreciate it.